So my patient was on kind of a vestibular and orthopedic kind of co-management, 64-year-old with just chronic dizziness. Just kind of a background of what setting I was in. I was in University Physical Therapy in Roanoke for 16 weeks, which was pretty much primarily all either orthopedic or sports-related kind of medicine. And so didn't get too many vestibular patients. So kind of going into the purpose, one of the purposes was just to provide education and information, kind of both to the clinic and to myself on the treatment of patients with vestibular/dizziness impairments. During that 16 weeks there, we saw a total of 3 vestibular patients, one being my case study and 2 more being 2 cases of BPPV cases. So both my CI and the 2 PTAs that worked there had very little experience, and myself actually had very little experience working with any kind of dizziness/vestibular type stuff. So it was a very good educational process. And then the second purpose was just to attempt a new approach for just treating dizziness disequilibrium that I hadn't really tried before. So getting into the history, like I said, 64-year-old female with a history of chronic dizziness that was kind of on and off for the past 7 years. She did say that that dizziness had led to a couple falls. None of the falls had resulted in any injuries, but she, again, still when you hear falls, it's kind of a red flag of, all right, we need to do something. She reported that dizziness affected things like working, driving, cleaning, getting into and out of her bed, working at her desk, interacting with her grandchildren. And because of just the dizziness, she avoided a lot of quick movements and often required things to hold on to when walking around the house when dizziness came on. So using furniture, things like that. She did not use any assistive device at all. She moved around pretty well, but when these dizziness spells came on, that's when things kind of got rough. And then just kind of other note that she talked about, she had recently, within the past month before the eval, she had recently moved into a new house, started a new job. She had retired, but then started another job that she said was more strenuous than her previous job that she had retired from. So she was doing that. It was a lot of desk work. And then her husband had also recently injured his hand that put him out of work. So overall, she was under quite a bit of extra stress. For her past medical history, she had Crohn's, hypertension, GERD, and diabetes type 2. 3 weeks before, when she saw a family doctor that did some just basic blood work, her HbA1c, kind of checking for diabetes level, was 7.1. For someone that is diabetic, the goal is to try to get that number under 7, and anything above 7, there could arise more complications with that diabetes. Based on our medications, that's kind of a list. The 2 that really stood out were kind of based on Davis's drug guide for rehabilitation of professionals is that's the salamine and the losartan. Those are the only 2 drugs that had adverse effects of possible dizziness. We took vitals, we took blood pressure. This was on the second visit because we were kind of thinking about possible orthostatic hypertension. So just laying down, it was at 124 over 82, and then when she sat up, it was 114 over 78. When you think orthostatic hypertension, you would think something more of 20 millimeters of mercury change in the systolic, so we were able to kind of rule that out. Her heart rate was a little high, but she said she was kind of nervous. We performed some ocular motor testing, both smooth pursuits and sarcoids. Those were both within normal limits. Then kind of began with vestibular testing, performed head thrust, and on the second attempt going to the left, she did report some dizziness. With head shaking, which she reported there was no noted nystagmus. And then with gaze stabilization, she did get quite a bit of dizziness, trying to, when just completing BOR ×1 is, that's when you just kind of focus on a point and move your head back and forth, trying to keep your eyes on the point, both in vertical and horizontal. She reported more dizziness doing more of the horizontal movement than the vertical. Balance, we performed the Romberg test. As you can see, the results are here. The big one that stands out is the condition 4, or the foam with the eyes closed. She was only able to hold that for about 5 to 7 seconds. According to Agraway, a score less than 20 on the condition 4 indicates a significant fall risk, and may be indicative of possible vestibular dysfunction. Sharp and Romberg and single leg balance, as you can see, the results there are pretty poor as well. So overall, she's pretty significant fall risk. We then performed BPPV testing, which both Dix-Hallpike and the roll test were both negative. We performed this the first visit, and we also performed it on the third visit just to recheck to make sure things like that. And both times, all results were negative, no complaints of dizziness, no nystagmus noted. And then for an outcome measure, we used the dizziness handicap inventory. She scored a 32 on, which indicates a mild handicap related to dizziness. We then did a cervical range of motion screen, and this is where we saw a lot of impairments with this. Flexion, as you can see, was the only thing that was within normal limits. Extension there was a severe decrease and some soreness in her posterior cervical spine. Left and right side bending were both moderate to severely decreased. Left rotation was decreased and right rotation was decreased with some dizziness. Overall, after we performed a cervical screen, she just complained of just kind of dizziness. We had to give her about 5 minutes for her to kind of settle back down before we moved on. We then laid down and we did kind of more of a manual just motion test of her just segments in the cervical spine. She was very decreased in motion, but I think this was more because of guarding than actual segmental restriction. So kind of after the examination findings, we kind of went through and looked at possible kind of diagnosis. So looking at BPPV, we were able to rule that out, again, because the Dix-Hallpike and the roll test were both negative. That orthostatic hypotension we were able to rule out because of the blood pressure change. Diabetes, this was something that kind of came up on our radar, and there was an article by Bawley that said vestibular dysfunction should be immediate consideration with patients with diabetes and complaints of dizziness. So just knowing her history of diabetes and that it can cause vestibular dysfunction, we and that relates more to kind of a peripheral or unilateral vestibular dysfunction. Medications, knowing that both that acetylcholine and that losartan could cause the side effects of dizziness, were also kind of on our list of maybe we should look into that more. Veneers, we were able to rule out because usually with that you would get the ringing, the fullness in the ear. And then unilateral vestibular dysfunction was something that definitely kind of came up, both related to that diabetes and just because of her basic symptoms of just that dizziness, poor balance, and just trouble walking, especially in crowded environments. And the last thing that kind of popped up as I was doing kind of research of how to treat this patient was cervicogenic dizziness. For those of you that don't know, cervicogenic dizziness, as defined by Reed, is symptoms of dizziness that arrive from the cervical spine. Lystad kind of described it more as abnormal afferent signals being sent from the cervical spine to the vestibular visual systems, causing disequilibrium. So basically, when we saw her just impairments of that range of motion that was pretty significantly decreased in that cervical spine, and just with her combination of dizziness and points of vertigo, we kind of said, like, well, maybe it could be more related to her neck, said the vestibular stuff. And then doing more research, most of the articles that I found on it of how to treat cervicogenic dizziness said use a combination of both manual and vestibular therapy. So kind of going back to this differential diagnosis, knowing that it's kind of unilateral vestibular peripheral vestibular dysfunction was a possibility, and the cervicogenic dizziness, using that both manual and vestibular kind of approach means we could kind of kill two birds with one stone. And so that's kind of what we were doing as we kind of go in the plan of care. Overall, for kind of PT diagnosis / impairments, the biggest things that we saw were, again, that decreased cervical range of motion, decreased gaze stabilization based on kind of that VOR test, and then decreased both static and dynamic balance. According to Christensen, they showed that with treatment of this, you can expect to show significant improvement after 6 weeks of treatment. So that was kind of moving into our plan of care. That was our plan, was to see her for 6 weeks, twice a week. we planned on using a multimodal approach, again, kind of based on that Christensen article that included manual therapy, postural and cervical exercises, gaze stabilization, static balance, dynamic balance, and gait, and patient education / home exercise program. So, any questions so far? Great. So, moving into treatment. So the first part of treatment was manual therapy. That came in two parts. The first part was kind of more mobilizations / manipulations of the cervical and thoracic spine. I found about 3 different articles that supported using more mobilizations and manipulations to the spine. One by Shrink said use of those helped improve range of motion and decrease dizziness functions. Another one by Yang showed that the use of manipulations helped increase proprioception in the C-spine. And with the combination of cervical stabilization, an article by Lee et al. Said using manual therapy and spinal manipulations helped with cervical vertigo by restoring normal movement of the joints, reducing pain and muscle hypertonicity, and thereby restoring normal proprioceptive and biomechanical functioning of the cervical spine. And then the soft tissue was based more on an article by Kallenberg that said the use of soft tissue helped improve range of motion and to decrease cervicogenic dizziness. And so each treatment she would come in, and this is usually what we would start with, just kind of some manual therapy of her neck, just working on that range of motion, just both increase the motion and increase almost the proprioception in that. The next part of the treatment was more postural exercises. So we did start with chin tucks. We progressed those by including more extension, the chin tuck plus extension, and chin tuck plus rotation, just to work on those deep cervical flexors. And then the other part was more scapular / more postural stuff, and so just kind of scapular retraction both in sitting and standing. With postural exercises, we also included a lot of just patient education on overall posture, especially while she was at work and sitting a lot, just keeping a good upright posture with that. Then the next part of the treatment was gaze stabilization. We started with just kind of the basic VOR ×1, so just that seated vertical and horizontal movements while focusing on the point. We were able to kind of progress this along by just also changing the point to be farther away, also increasing how far she would go. We did a lot of patient education the first couple of visits to make sure she was just keeping her symptoms down, not increasing that dizziness too much. We're able to progress just kind of that gaze stabilization to, instead of just vertical and horizontal, to also kind of diagonals. And then on the third visit, we started incorporating more eye-head coordination, moving some more of that VOR ×2. And so this included just kind of seated head eyes in the same direction. So focusing on point and just kind of watching with both moving the head at the same time. And then next part, we progressed that even further to moving in opposite directions. And so focusing on that point, going in opposite directions. And then we progressed that even further in the treatment with kind of seating, reaching down and picking up objects off the floor. So these are just a couple of pictures of kind of what we did. So that first one in the top corner is just the basic kind of VOR ×1. Then the other one is more eye-head movement, same direction. The bottom, I guess, right thing is what we used to progress it even more, and that was more kind of that we included more in the dynamic balance and gait. So that's kind of focusing on an object while you walk, and then performing head turns while you walk. That was kind of more advanced. And the last picture down there is just picking up objects off the floor to do that. So the next part of treatment was static balance, and this was pretty formal. We worked a lot on this. We kind of performed Romberg, sharpened Romberg, single leg stance. The first 3 treatments, she was unable to hold single leg stance longer than 10 seconds, but she was able to progress and hold it on both legs for greater than 30 seconds. And so showed quite a bit of improvement in this. We also challenged her more by arm placement and opening and closing the eyes, just to continue working hard against the balance. Next part of the treatment was kind of more dynamic balance and gait. We attempted on her second visit, so the first treatment day, to perform a tandem walk. She did very poor at this. She lost her balance 5 times within 40 feet. She required minimum assistance just to make sure she didn't fall. But by then we were able to progress her to walk over 100 feet with only supervision and 2 just minor losses of balance. And she showed quite a bit of improvement just in more of that dynamic balance. About visit 4, we also included a couple more kind of dynamic gait type activities. So kind of walking with head turns, walking with quick stops and turnarounds, so kind of more of a 180 turn to a stop, and then also progress to walking with a 360-degree turn and then continue to walk. So that was just kind of as she progressed in her exercises. For home exercises, the first day we sent her home just with those chin tucks, and so just kind of perform the basic chin tuck. We didn't really include the extension or the rotation right away, but we included that later on for her to start doing at home. We also gave her kind of basic gaze stabilization, so more of that kind of VOR ×1, just keeping that more of that vertical and horizontal head movements. In an article by Hall, it said that the total time for eye movement exercises should not exceed 30 minutes per day. So we told her just to perform her kind of exercises twice a day for 10 minutes each time, just to make sure it didn't cause too much dizziness and almost increase those symptoms too much. And then for education, kind of like I said earlier, was a lot of education on like sitting posture and her desk or ergonomics, just to take a look at where her computer was and just making sure she wasn't moving around too much at work and everything. It's kind of eye level there for her. So about 4 weeks in at visit 6, we performed a progress note. At this time, her dizziness handicap inventory score was 20. Still indicated that was in that mild handicap range, but overall, compared to what it was at the beginning, which was 32, it did show quite a bit of improvement. Her cervical range of motion, flexion was still within normal limits. Extension was still the biggest kind of impairment related to the cervical, was still a kind of a mild to moderate decrease. Rotation improved. A little to the right was still decreased. While performing this, she didn't really complain of too much dizziness, and overall showed pretty well. And then kind of like I said with balance earlier, her single leg stance by this point was 30 seconds on each side. So showed quite a bit of improvement of this. After this, she missed 3 weeks because she got the flu, unfortunately. And so she had to cancel for 3 weeks, and then she finally came back after this time. While she was away, she said she felt she regressed quite a bit just overall with everything. She said she didn't really perform any of her home exercises during that time because she was just too miserable, and trying to do anything like that would just cause increase the symptoms. And so we saw her that first time after she came back, and then the next time after she came back, she requested to be discharged. So kind of at the discharge, we took one last screen. Her dizziness handicap inventory was 22, so it went up a little bit. It's still kind of right where I was at, but for being gone for almost 4 weeks at this point compared to the progress note, still being at that 22, I felt was pretty good. Her range of motion looked pretty great overall. It's still a little limited extension, but everything else was within normal limits. Her static balance was good, especially on that Romberg. The condition 4 there was 25, so that's over the 20 seconds kind of that she had to gain. So she was no longer kind of that fall risk that she was at the beginning. Again, single leg stance was 30 on both sides, and then the other, like I said, with tandem, she was able to walk 100 feet with only 2 losses of balance. So overall, the patient said she felt she was doing better, but she still really wasn't where she wanted to be. She still felt she was just kind of, she would say, kind of off, just kind of some dizziness here and there. She said she really felt it was more for diabetes related, more medication related. She would rather go see her primary care physician and kind of who was keeping track of her diabetes and medications that she would possibly have to maybe change up her medications. That was more based on that, not just what we were treating. So kind of overall, some of the limitations that I felt we had. The first one is the flu. and missing 3 weeks because of that, kind of interrupting our whole plan of care. And I felt she was doing well, she felt she was doing well, and she felt that was kind of a big regression to our treatment. Another limitation was her not being seen for the full plan of care. She kind of put it together. We saw her total for 8 visits. We hope for at least 12. And so I think possibly if we would have seen her for that whole time, that she would have potentially shown a lot better improvement with that dizziness. I think another one of the big limitations was being an orthopedic sports-based clinic and not having much experience with vestibular patients, that we might not have provided the best treatment for her. I think the treatment we did provide was good and showed improvements, but I think being at a vestibular like specialty clinic could have helped her a lot more in her treatment. So kind of my overall thoughts is that treating this kind of cervicogenic dizziness did show improvements with overall kind of static and dynamic balance or range of motion and kind of gaze stabilization. And so I think as I kind of go forth into the clinic and I would see another patient that presents with these symptoms, I think I would continue to use both a manual and vestibular approach to a lot of these patients, just to continue to see how that kind of works overall. Any questions?
You said you performed cervical manipulation. Sorry if I missed it, but what more specifically did you do?
So cervical was high dog and mid dog, HVLA, so high velocity, low amplitude, kind of both to kind of middle spine and upper and middle spine. And then we did more thoracic manipulation, so kind of a PA thrust to her kind of mid upper thoracic spine.
Yes. She was at vestibular.
So if it wasn't, I think I even talked to Brian within the past week since we've been back, who wasn't a specialty clinic. I kind of talked over my case with him. He's like, oh yeah, we had these patients all the time, and just being able to kind of see your symptoms right away and be able to treat those right away, and kind of knowing when to best progress exercises and things like that would have been a lot more of a benefit for her.
I'm still a little lost because I mean, it looked to me like you hit stuff. So what specifically would you have done differently, or did your colleagues suggest would have been different or better?
Or like, what would I have done differently?
Yeah, like just following up on Van's question, like what did your colleagues you discussed it with? You said they had things that you thought that would have been better. What?
I think not just better, but a lot of these exercises, kind of knowing how long to do the exercises. So it's more of the kind of thing of kind of giving her, all right, let's do this for 5-10 minutes, these kind of gaze stabilization exercises, and kind of moving on. So we didn't really know good parameters, I guess you could say, of how long to do each exercise. And kind of like I said, like when to then progress the exercises. And I think for a vestibular specialty clinic would know that a lot more than what we knew.
Okay, that answered one of my questions. Thanks. One of my questions is why the time on the gaze exercises rather than like to do them 2 symptoms.
Right.
Others? Oh. Yeah, I've got more time. I have my hand. Oh, what was overall, like, I guess I might have missed this right from the beginning when you were talking about your plan of care, but I never saw a frequent, I've been writing something like, was it planned to see her twice a week or once a week?
Twice a week for 6 weeks.
Okay. And then she just missed some because you said at 4 weeks she had 6
Missed some.
visits.
One because of the flu, and then missed 2 other times just because of personal reasons. The main one was that flu for 3 weeks.
Okay. And then goals? And is that similar one?
So goals for her were kind of based on her impairments. So hoping for full cervical range of motion, hoping for improved kind of static balance. So being able to, I think we did that sharpened Romberg with the eyes closed for greater than 20 seconds to get her out of that significant fall risk. And then I think our last one, so that was static balance, and then more of that kind of gaze stabilization, kind of home program, making sure she was just kind of independent with that, being able to perform those at home without any complaints of dizziness.
What was her hip abductor strength?
I don't know. We did not test strength of the lower extremity.
Would that have had anything to do with her balance?
I definitely could have. Something.
Balance got better. I mean, her
Right.
leg and all that got better. Was it better because she was working on? Did you give her like standing in a corner, practicing some of those? Was that part of the home exercise program?
Home exercise for that cervical kind of stabilization, kind of seated gaze stabilization stuff.
So if it was getting better without working on the strength, probably strength wasn't a problem. But
Right.
aging, I hate to say 64 is aging, but yeah, I mean, like, especially females, for some reason, lose that hip abductor strength. And
Right.
so, like, she's already out because a lot of women in their 60s, and certainly by the time they hit 70 or 80, it's like your hip abductor strength is like non-existent. Males too, but women even more. And that's really important, of course, for stability and standing.
What were her initial her Romberg and her regular Romberg? The first couple stages, I know you're really focused on 4, which tends to be the most vestibular center.
For the eyes.
So those are pretty sure, yeah. Like you said, you're the only one that she did
Yeah.
pretty well. I guess she kind of did pretty well on the rest of them until we got her up on the foam, and then that's when she started getting bummed. Even kind of the conditions 2 and 3, she was 20 seconds, and so those were still, she was pretty shaky with those as well. So still kind of difficulty with those, but then as you can see, pretty significant decrease in her time when she got to that condition 4.
Why did you pick her to present?
Just because it was something different than what we saw every day, and I knew it'd be good for me and good for my clinic to research vestibular stuff a little bit